I want to talk about the EXaLT trial, which is a trial of home-based exercise and motivational program before and after liver transplantation. Obviously we struggled with the acronym, and we've likewise struggled to get the study up and running in view of COVID. So what I'm going to talk about today is essentially why perioperative exercise might be important for liver transplantation, why we feel this study is justified. A little bit about the background to the study, how it sort of the collaboration that really allowed the study to happen came about, bit of sort of running through the study design, a bit about how we got it funded, and then just a brief touch on my sort of opinion on how prehabilitation might progress in future. So I think if we're talking about why perioperative exercise might be important for liver transplantation, it's important to know what the most important extra-hepatic complications of end-stage liver disease are. So those are frailty, sarcopenia, and impaired aerobic capacity. All of these are associated with pre- and post-liver transplant mortality. So death and delisting on the liver transplant waiting list, as well as post-operative mortality. In addition to that, they're associated with a variety of adverse perioperative outcomes and prolonged requirement for oxygen therapy after transplant, that sort of thing. They also affect longer-term outcomes like quality of life. These are very prevalent in the liver transplant population, so frailty affecting about 25%, sarcopenia about 40%, depending on how these are defined. And aerobic capacity is severely impaired in 54% of patients in one large study. So by severely impaired, we mean that for age and sex-adjusted norms, the patients fall below 60% of the expected VO2 peak. So really quite impaired. As well, the trajectory for most patients on the waiting list is not good. So patients can wait anywhere from just a few days to up to 2 years for their transplant. And in most patients, there is a trend towards general deterioration. And worsening frailty on the waiting list, some work from San Francisco, in fact, showed that worsening frailty on the waiting list is associated with death or delisting, which isn't surprising. So far, really, management of patients on the waiting list is focused on sort of acute hepatic complications of end-stage liver disease, things like hepatic encephalopathy, ascites, and bleeding, which are typically managed as inpatient episodes. So, the rationale for an exercise intervention in liver transplantation seems clear to us because liver transplantation itself is an enormous physiological stress. It's associated with enormous fluid shifts, hemorrhage, coagulopathy. And we know from other patient groups that the only evidence-based treatments for sarcopenia, frailty, poor cardiorespiratory capacity are adequate nutrition and specific exercise. But there are specific challenges to delivering exercise to this group. So we've talked about the prevalence and the severity of frailty, sarcopenia, and poor cardiorespiratory fitness. Alongside that goes sort of low exercise literacy. So patients really aren't familiar with exercise. They don't really know how to exercise in many cases. So that's often a barrier to exercise. In addition, we have this uncertain, often long duration between the decision that the patient needs an operation and therefore goes on to the transplant waiting list and the surgery itself. So in some cases, that interval is so short that we might think there's no opportunity for pre-optimization. In some cases, it's so long that maintaining motivation to exercise becomes an issue. In addition, there's only 7 liver transplant centers across the UK, serving 66 million people. So there's a huge geographic dispersion of patients at each liver transplant center. So that means that, for instance, having patients come into their liver transplant center to exercise is just not feasible for most patients. In addition, patients with severe liver disease are disproportionately burdened by socioeconomic deprivation, social isolation, anxiety, and depression, which we know are all barriers to exercise. So I should start with a little bit of background. So I think we understand the problem and why we wanted to do the study, but how did the collaboration, this is a collaboration between the Royal Free and Birmingham, And I should say that the study is not currently up and running. We're planning to start recruitment in November. So I'm going to talk through really the sort of formation of the team, the study development, that sort of phase of the project. So essentially, throughout 2017, 2018, Birmingham and the Royal Free were both carrying out pilot studies of prehabilitation in liver transplant patients in parallel. And then my predecessor on the liver transplant anesthesia fellowship at the Royal Free, Claire Morcaine, met with the team from Birmingham at a conference, and they recognized there was potential for collaboration. And I was handed over sort of, would you be interested in sort of pursuing this collaboration with Birmingham? And I sort of said, sure, sounds like a great opportunity. I started getting in touch with them and arranging some meetings. So that's how it sort of came about. And we've ended up through a process of obviously a lot of meetings and expanding the team as we went along, designing a randomized controlled trial across 2 centers, Royal Free and Birmingham, with 2 arms. So an exercise and behavioral, quite a complex intervention versus a standard of care group. And we're looking at a primary outcome of quality of life at 6 months after transplantation. So we'll come on to that. And then there's, in addition, 2 strands of mechanistic work that we're going to look at in a subset of patients. So 1 physiological and 1 psychological. The population we're looking at are adult patients awaiting liver transplantation at either the Royal Free or Birmingham. Now, patients are listed based on local MDT decision-making processes. And although there are guidelines on how that process should be conducted and who should be involved, views on which patients would be considered fit enough to list will vary from center to center. So I think that actually emphasizes the importance of running this study at more than 1 center, because the actual entry criteria to the study being listed for transplantation may vary at different centers. And I think we need to show that this study, that the intervention would be generalizable to patients at different groups that may be listed at different levels of frailty, sarcopenia, functional impairment. So a number of exclusions. So it's not really feasible to exercise patients who are listed for super urgent transplant are generally critically ill, and it's not possible. Patients having multi-organ transplant, just because of the heterogeneity that would introduce. Non-cirrhotic liver disease. So we feel that although these patients are frail for different reasons, these are patients with malignancy that's unresectable, and so they require a transplant, or patients with polycystic liver disease. So these patients, they may be frail, but they tend to be more robust than the cirrhotic group. And we feel that the pathophysiology of their frailty is probably different. Also, patients who can't probably adhere to an exercise intervention. So patients with severe hepatic encephalopathy, or patients who have oxygen-dependent hepatopulmonary syndrome at entry to the study, so on-home oxygen. In terms of the timing of recruitment, when the study opens, we'll try to recruit all patients on the waiting list who meet the inclusion criteria. Obviously, the length of the waiting list varies from time to time, so we're not sure how many patients that will be. And then we're going to recruit patients on an ongoing basis at both centers, approximately 2/3 of patients at Birmingham, which is a bigger center, and 1/3 at the Royal Free. So the exercise intervention is going to incorporate, so it's going to be home-based, first of all, so to address the issue with geographic dispersion, and also to offer a sort of cost-effective form of prehabilitation. We're going to incorporate both resistance training and aerobic training. So the resistance training, the intensity of the exercise will be set by rating of perceived exertion. So the patient's internal experience of the exercise and how they feel when they're conducting the exercise, and how close they feel to muscular failure. So that's how they're going to set the intensity. And we're going to get them to do body weight and elastic band resistance exercise. And we're going to progress them from sort of quite easy exercises, depending on their baseline level of fitness, through to more difficult exercises by modifying the form of the exercise. So for instance, eventually after doing a simple 2-legged squat, they may progress to the point where they can do a squat on 1 leg as they get stronger. The aerobic training will be the patient's choice of modality. So it depends on their access to facilities and equipment, but they may want to run or walk. They may want to row or swim. It just depends what their previous experience and what they find enjoyable. Again, we're going to use RPE to set intensity, and RPE is a well-validated measure of intensity in both resistance and aerobic training. And we're going to progress their aerobic training by adding volume, so duration of exercise. And we're also going to, throughout various periods of the study, we're going to remotely monitor the activity levels of patients, both to, these patients are known to be highly sedentary, so they tend not to move throughout the day to a greater extent than patients in other groups, such as patients with cardiovascular disease. So we're interested in seeing how the exercise intervention modifies that sedentary behavior, as well as general overall activity throughout the day. And also we're going to use the remote monitoring to sort of monitor adherence to the protocol as well. Alongside the exercise intervention is going to be a behavioral intervention. And we feel this is really key to promoting adherence among the patients. So while this is a form of psychological support, it's not aimed to reduce symptoms of anxiety or depression, for instance. What it's aimed to do is improve adherence to the exercise and support patients through that. So it's grounded in a psychological theory called self-determination theory, which sort of posits that if patients feel people are motivated to do an activity, if they feel they have a degree of autonomy in the performance of that activity, if they feel competent when they perform it, and if they feel related to other people in doing that activity. So we try to promote those aspects. And what we wanted to do was, of course, make this intervention feasible for rollout as standard of care eventually. So we're actually going to get our physiotherapists who deliver the exercise intervention to undergo a 2-day course to learn how to deliver this self-determination theory form of support. So they'll actually be delivering that via an initial face-to-face meeting with each patient, and then via telephone health calls throughout the study. And again, we're going to be, the physiotherapists will also have at their disposal the remote monitoring data, so they can kind of have an objective view of adherence in addition to what the patient is is telling them. So we're going to compare our intervention against a standard of care group. So this is going to take the form of essentially a written exercise leaflet, advice leaflet. We're going to reinforce that with verbal advice, both initially at study entry and at 6 weekly clinic visits. So patients typically attend a liver transplant waiting list clinic every 6 weeks. And so we'll continue to give standardized advice at each of those visits. This actually is more than most patients at most liver transplant centers across the country are currently receiving. So what we wanted to do, we'd anticipated that probably there will be progress in the standard of care. So throughout the sort of next 5 years that the study runs, we will probably see that more patients will be receiving more standardized advice. And so we wanted to be at least a couple of years ahead of the curve in terms of setting the standard of care, so that we're not disadvantaging our patients by recruiting them to our study, and so that we don't have to vary the trial protocol substantially mid-trial. So I mentioned that our primary outcome is quality of life at 6 months. So specifically, we're looking at improvement in the physical component summary score of the SF-36 version 2 health-related quality of life questionnaire at 6 months post-transplant. So that's a bit of a mouthful. In general, why have we chosen quality of life? Well, actually, that came mainly from our patient and public involvement groups and our experience actually talking to patients in the study development process. What patients really said they would want from an exercise program and from their transplant in totality is the ability to do more, to spend more time with their family, to get out and about, to look after themselves to a greater extent than they are currently, to get back to work, those sorts of things, which all tie in quite nicely with a quality of life measure. Additionally, funders aren't so interested for a trial of this size and for the funding that we were seeking. They're not so interested in sort of perioperative outcomes like complications or length of stay. They're interested that we collect that data, but they wouldn't tend to fund a trial, which was interesting to me. It was part of my learning process through this study. Why at 6 months? Well, actually, we wanted to measure outcomes at 1 year. But when we actually projected the trial timeline and the rate of recruitment, that would have put us outside the sort of feasible window that the funders would accept. So we cut it back to 6 months post-op. That also probably will reduce our dropout rate in terms of collecting the final outcome just slightly. So that's probably to our advantage. But we really want to be reflecting longer term outcomes, not just how they are the week after the transplant. Patients actually care how they are 6 months, a year, 5 years after their transplant. Why have we used this specific quality of life measure? Well, we've used it because it's well validated. There's good data out there on which to sort of base our sample size calculation for patients with severe liver disease. So that brings me on to how we actually calculated our sample size. So essentially, we know that patients with severe liver disease have a physical component summary score of roughly 40. And the standard deviation varies across different studies, but somewhere in the range of 8 to 24. We know that liver transplant alone improves the physical component summary score by about 4 points. So we've got to bear that in mind when we're looking at the difference, the eventual difference between groups. Previous studies of post-liver transplant exercise, so sort of rehabilitation after transplant, have demonstrated a total improvement of 8 to 9 points. So that's the improvement that patients get so this was an uncontrolled study. They tend to improve by about 8 to 9 points. That incorporates both the 4 points that they probably got from their transplant and an additional, say, 4 or 5 points that they would have got from the exercise program, in theory. So we think that our exercise intervention is going to be more successful than that. We think that we can achieve a difference of 12 points in the intervention group, and then the 4 points that the evidence suggests we'll see in the control group. We've presented this to our patients. They feel that a 20% difference, so 8 points on a baseline of 40, would be a significant change, and they would feel that's valuable. So we've nominated this. We've called this our minimum clinically important difference. We've taken a midpoint of the literature reported standard deviations. We've applied a 90% sort of power and a typical type 1 error rate of 5%. And that yields a sample size of 172 patients required. So that's 86 per group with 1-to-1 randomization. But unfortunately, we expect about 35% of patients to drop out of our analysis. So that's 30% that just won't be transplanted in time. So we're not saying that the adherence to the protocol is going to be terrible and patients are going to drop out for various reasons. We're saying that 30% won't be transplanted in a feasible time frame to measure their outcomes. And then 5% will drop out for other reasons. So, not wanting to take part for whatever reason. So that bulks up our target recruitment to about 266 patients, 133 in each group. We also have a number of secondary outcomes that we're going to be measuring. So we were asked in our phase 2 application, we were asked actually to resubmit, and I'll come on to the funding in a bit, but they asked us to resubmit our application. And one of the criticisms was that we didn't have an objectively measured outcome. And so we felt that because of course, quality of life is answered by patients in questionnaires. And so we actually nominated the Comprehensive Complications Index as a key secondary outcome. We're going to measure that at 6 months post-transplant. We've been able to demonstrate that we probably have adequate power to detect a difference between groups. And really, the reason we've used that rather than say, typically in studies measuring complications, they'll measure sort of worst complication, highest Clavien-Dindo grade. So, but unfortunately, patients who have liver transplant usually experience multiple complications. Most patients will have at least one complication. So what we wanted to do was reflect the Comprehensive Complications Index incorporates both the severity and number of complications to produce a total score reflecting the total morbidity experienced by the patient. So we think that's a more accurate reflection of the experience of our patients. In addition, we're going to measure a variety of other outcomes, so mental component summary score of the SF-36, measures of frailty and physical fitness, including specific liver frailty measures, adherence to the exercise intervention measured by the electronic physical activity monitors, pre-liver transplant morbidity, so severity of liver disease as assessed by the EXaLT, number of hospital admissions, duration of hospital admissions, and of course, mortality and delisting pre-op. Then post-op, we're going to look at length of hospital and critical care stay, as well as mortality over various durations. We're also going to try to recruit patients to a sub-study, a physiological sort of mechanistic sort of a sub-study within the overall trial. And what the question we're trying to answer is, what is the mode of action and the dose response of the exercise intervention on physical fitness and muscle biology? So to address that question, we're going to ask a subset of patients to come in and have serial measurements of muscle ultrasound. So we're looking at thickness of the muscles at key locations, so as a measure of sarcopenia, as well as muscle architecture. We're going to, as markers of muscle health, we're going to be looking at serum myokines. We're also going to ask the patients to undergo cardiopulmonary exercise testing. So we're going to measure all the conventional parameters there. And as well, we're going to interrogate the electronic physical activity monitors to assess the dose of exercise that patients appear to be receiving. The second mechanistic question is really how this theory-based motivational program affects adherence to and engagement with the exercise program. So we have some exercise psychologists involved with the study who are going to administer validated questionnaires that assess sort of readiness to exercise, enjoyment from exercise, motivation and engagement with exercise. So we'll be doing that over the course of the study. And we're also going to correlate that with the objective data from the remote monitoring. So the way that we funded this study is through an EME grant. And essentially this type of grant is designed to fund studies evaluating interventions with the potential to produce a step change in care. So they want studies that actually could be rolled out to patients. You know, they're at that stage where it would be feasible with the results, with positive results from the trial, to roll this out as a standard of care. They also want some mechanistic work to support the study and sort of explain why it's worked if it has, or why it hasn't worked if it hasn't. It's a two-stage grant proposal process. As I mentioned, we were asked to resubmit at stage 2, which I think is quite unusual. It's usually a reject or accept at stage 2, but we were asked to resubmit. And we did, and we're successful. So we've secured £1.3 million in funding for the study. And we've had some substantial delays trying to get it open for recruitment, but we're expecting to start recruiting in November, all going roughly according to plan. Why were we successful in getting funding for the study? Well, in my opinion, it was partly because both centers had published pilot work, so it demonstrated the ability to deliver a prehabilitation intervention to these patients. We have a strong multidisciplinary team. There's there's input from hepatology, psychology, physiotherapy, a variety of specialties that each bring their own expertise to a study like this with a complex behavioral intervention, and I think that's necessary. The team has functioned together really well. I would say that's owing to strong leadership, clearly defined roles, and a lot of respect for the expertise that each other brings to the study. I think also we have I would say an innovative but also pragmatic intervention which could feasibly be rolled out as a standard of care. So we're not trying to do something that's too expensive or that patients are unlikely to adhere to, and which would make it unlikely to be able to be rolled out at all liver transplant centers across the UK. I'd also add to this, it's not on the list here, but we had really strong involvement from patients throughout the study development process. They had input into the exercise protocols, the behavioral protocols, as well as our choice of outcomes that we're going to measure as well. So that was extremely helpful. And I think we were able to demonstrate that in our grant application. It was absolutely crucial to our success. In addition, I think we offer pretty good value for money. So funders, unsurprisingly, are interested in getting the most for their money. Because this is a home-based intervention, it makes the trial much less expensive to run. Also, having the physiotherapist deliver the behavioral intervention, that reduces the number of trial personnel that need to deliver the intervention. In addition, we had some, it's relatively small amounts of money in the context of the overall grant that we were seeking, but we had some charity funding of the activity monitors, which helped. And we were using existing ultrasound and CPET equipment towards the study. And one thing that was really interesting for me is that one of the co-chief investigators of the study, Matt Armstrong, who's a hepatologist in Birmingham, he emphasized in the grant that his mentorship, he has a number of senior mentors who have committed to sort of guiding him through the trial and so on. That was viewed by the funders as good value for money, because essentially what they're getting is expertise from out with the trial that they're not funding, that's contributing to the running of the trial and ensuring its success. So I thought that was quite interesting. So this is the study team, as you can see. So co-chief investigators are Matt Armstrong up in Birmingham and Dan Martin, who has recently moved to Portsmouth, I believe, but he's obviously well known to the Royal Free and UCL. In addition, we have physiotherapists, we have sort of trialists, so that the director of the Birmingham Clinical Trials Unit, Claire Milliken, and myself from, I was at the Royal Free, now at the Marsden, but both anaesthetists. And we have a couple of exercise psychologists with expertise in delivering this behavioral intervention, as well as statistician and trial managers. So that's really the trial to date. As I said, we haven't started recruiting yet. But I think in terms of prehabilitation more generally, where I see it heading, I think really we need to start developing prehabilitation specific expertise and training for professionals. And I think that can be a multidisciplinary group of professionals, but probably physiotherapists and anaesthetists. Because I think actually there may be an assumption that physiotherapists know how to design and deliver an effective program to improve cardiorespiratory capacity and muscle strength, general muscle strength. But actually that's a small component, I think, of most of their training. Some of them have an interest in this area and are very well informed, but I think that's variable. So I think we need to sort of start as we understand better what exercise is optimal for prehabilitation. We need to start developing those programs. It's important to recognize that not all exercise is the same. There can be this sort of, as long as we just get patients moving, then we're achieving what we want to with prehabilitation. But actually, there's plenty of data, there's plenty of data from the exercise physiology literature that shows that training needs to be specific and obey principles of progressive overload if you're going to achieve improvements in, for instance, aerobic capacity and muscular strength. So, if we want to achieve those goals, then just getting patients moving or making them tired isn't the way to do it. And what we're really trying to achieve here is what's called concurrent training, which is development of more than one physical capacity, so aerobic training and strength training, to achieve different physiological qualities. And that's actually a tricky area, and there are interference effects from aerobic training on strength development that need to be respected. And actually the time course of the training sessions, so how you conduct the training sessions, separating out your strength and endurance training, can lead to superior adaptations. So these are things that I think a lot of the prehab programs that I see being rolled out practically at this point aren't obeying. I think we need more research on strength training in the perioperative context, because essentially frailty and sarcopenia are, increasingly recognized as risk factors for perioperative outcomes. Strength training is the form of medicine for these conditions. So we need to be looking more carefully at how we can improve patients' strength and muscle health preoperatively and how that impacts on outcomes. We need to focus on pragmatic settings, homes and community gyms, because it probably isn't going to be practical to bring patients into hospital for prehab. And we need maybe better evidence of long-term behavior change. I think this is how we can prove the sort of cost effectiveness of prehab. Is sort of the prospect of having surgery a teachable moment for patients in adopting exercise behavior? We know that in general, exercise advice is very unsuccessful. We know it's not effective in most cases. So, but is this a key moment where it might be effective? And how do we go about fostering that sort of long-term exercise behavior? And then I think we need, a robust health economic analysis of some of these programs to just assess what's actually going to deliver benefit, value for money. So thanks very much. Appreciate your time. Happy to answer any questions.